Delori. I am part of the group that works with the Fund Healthcare Not Warfare working group of the Massachusetts Peace Action. And I think that we have an absolutely wonderful presentation this evening. This is part of our ongoing series of seeking women's health justice. And this evening, what we'll be looking at is women's health justice for incarcerated women. We have three exquisite speakers this evening. We have Sarah Nawab, who is the director of the Women's Incarcerated Condition and Reentry Project of the Prisoners Legal Service of Massachusetts. Michael Horrell, who is the director of the Healthcare and Disability Project of the Prisoners Legal Service of Massachusetts, and Angelia Jefferson, who is a fellow counselor for the incarcerated and formerly incarcerated women and girls. And they will each introduce themselves a little bit more so that I don't spend the extra time doing that. What we will do is have the speakers speak for 10 to 12 minutes each. After that, we will have question and answers. If you have any questions for these speakers, if you could just put it into the chat, and our colleague Ciara Hunt will be checking those out and presenting them to the speakers when we get through. Just as information, you will be receiving in a day or two a resource sheet that we have put together, and it has resources just a few resources relating to the issues, and also a wonderful opportunity that the Rutgers University Press has given us is that they are providing us with a discount, a 30% discount of any books within their catalog, as well as free shipping. So that will be on the resource sheet when you get it. So without further ado, I would like to introduce Sarah Nawab, who will begin talking about how healthcare is organized within the prison systems. Sarah, please.
Thanks, Catherine. Hi, everyone. My name is Sarah Nawab. I use she, her, hers pronouns, and I'm an attorney with Prisoners Legal Services of Massachusetts and the founder and director of our Women's Incarceration Conditions and Reentry Project. So I just wanted to give a little bit of background on, just a little bit of factual background on women's incarceration specifically, and women's healthcare issues on the inside, and also do a little bit of setting of the political stage of why this is always important and why it's particularly important right now. So a lot of the time when we think about incarceration, we think about men, because the vast majority of people incarcerated are men. But the reality of our system is that we also incarcerate women, and that incarceration is really harmful to women and their families and our communities. And it has a unique harm upon families, especially. And with regard to healthcare specifically on the inside, I'll just kind of give a little bit of background of the system in Massachusetts. MCI Framingham is the women's prison in Massachusetts, and then there are also a number of jails throughout Massachusetts that also incarcerate women. And then beyond that, of course, there are many transgender women who are incarcerated in men's prisons. And so that's sort of an understanding of the landscape that we have here in Massachusetts. And in Massachusetts, all the state prisons and many of the county jails contract with a private organization called WellPath to provide healthcare to incarcerated folks. And I don't want to step too much on my colleague Mike's feet, who's going to talk a little bit more about the specifics of those contracts and how they're so harmful to folks inside. But just as background, the healthcare inside is privatized. And so one of the biggest issues we hear at PLS is a lack of access to healthcare. So for women, for everyone across the board, it's a lack of care for folks who age. We have one of the one of the oldest prison populations in the country. It's a lack of access to proper healthcare screenings as folks get older, a lack of access to pain management care. For women specifically, this can result in a lack of adequate testing for breast cancer, cervical cancer. And in terms of pain management, I think a unique issue that I hear about a lot on the inside is just with regard to something as simple as getting the proper size brassiere to manage back pain. And that in and of itself is such an issue inside. And then for transgender women, accessing gender affirming healthcare is also extremely challenging. And so the reality is that prisons are not set up to provide adequate health care to people. They are not places of care. They are not places of healing. They are places that are designed to perpetuate harm. And that's really important to bear in mind right now, especially because there are plans right now to build a new women's prison in Massachusetts, because the current women's prison, Framingham, is the oldest women's prison in the country, and due to the Department of Corrections neglect, is in a great deal of disrepair. And so people are moving towards trying to build a nice new prison with the hope that if we do this, suddenly the healthcare is going to get better. And the reality is that it's not, because the lack of adequate healthcare inside is not a result of, the dilapidated conditions in Framingham or in any other prison throughout Massachusetts. It's really a matter of culture, and the fact that the culture of the Department of Correction and the culture of corrections in general is not one of rehabilitation, whether it be for, issues of medical care or issues of what folks do when they're on the outside. So based on all of that, one thing that's really, really critical when it comes to healthcare, and particularly with regard to women's healthcare and these plans to build a new women's prison, is instead of investing there, investing in decarceration, because the only safe place when we're talking about seeking justice for women's healthcare is on the outside. So investing in care on the outside, investing in community systems of care, community systems of healthcare, community systems of mental health care. And on the point of mental health care, I think it's really important to note that women disproportionately on the inside experience really high levels of mental illness as compared with men. Something of 70% of women in Department of Correction custody have open mental health cases, meaning that they're dealing regularly with a serious mental health issue. And that's sort of by design, right? Because the systems and patterns in place that lead women to incarceration a lot of the time involve really traumatic situations, domestic violence, sexual violence, and then they get inside of prisons and jails, and all of those same systems of gender violence are recreated and really make that trauma compounded and lead to exacerbating mental health issues instead of actually healing those mental health issues. So prisons and jails are not places where medical and mental health care are going to be prioritized and are going to be adequate, which is why in this moment it's really important to think through and focus on solutions that actually will help get women health justice, which includes decarceration, getting women out, and using money instead of on a new prison, funding community systems of care, including health and mental health care. So hopefully that's sort of a bit of background from my end. And I think I probably can pass it over to Mike from here.
Wonderful. Thanks so much, Sarah. Thanks to everyone for inviting us here to speak and for attending. My name is Mike Corral. You see him pronouns. I'm a staff attorney at Prisoners Legal Services, and I'm the director of our Healthcare and Disability Project. I'm going to talk a bit tonight about privatization of carceral healthcare. And I thought I'd give sort of some background on where we are and how we got there from a national perspective first. So systemized carceral healthcare and mass incarceration really arose together in the US. A couple things happened at the beginning of the 1970s. First, we saw the start of the explosion in people we have incarcerated here. The US prison population in 1970 was about 200,000. 20 years later, it was up to 600,000. And 20 years after that, it was up to 1.6 million. So at the start of that sort of climb in 1976, there was a decision from the US Supreme Court in a case called Estelle v. Gamble that held that a prison administrator's deliberate indifference to serious illness or injury violated the Eighth Amendment. So those two things, the sort of increasing number of people in prisons, along with this liability to prison administrators for failure to treat people's sicknesses, led to a lot of increased litigation over medical care. And so to avoid liability, carceral institutions started to formalize and incorporate provision of healthcare into their operations. That led to increased spending on healthcare, which they sought to mitigate by outsourcing it to private providers who marketed themselves as being experts and who promised to bring cost savings. So by 1999, about 32% of prison systems in the US had a private healthcare provider. By 2016, that was up to about half. By 2018, it was up to about 62%. To just give you a size of the market here, a 2022 estimate put the carceral healthcare market in the US at $9.3 billion. So it's a fair amount of money. And I'll go over some of the major players in the market. There are a number of large, mostly privately held companies that are sort of the repeat entities that we see over and over again in these different jurisdictions. Horizon is one of the big ones. In 2020, they served more than 140 facilities in 15 different states. They recently rebranded as the company called Yes Care and are in bankruptcy proceedings trying to offload a lot of the liability that they've incurred from all of the lawsuits over the negligent care that they've been providing. WellPath is another large one that we see frequently, including here in Massachusetts. It's owned by a private equity company called HIG. It was sort of an amalgamation of a couple previous companies, one of which was founded by a former Massachusetts DOC correctional officer who's currently serving 3 years in a federal penitentiary for bribing a sheriff in Virginia to award the company a healthcare contract there. Some other names you'll see pop up are Centurion, VitalCore, NAFCare, Prime Care Medical. I think the big takeaway from these different companies is you should know there's a lot of turnover, a lot of mergers, a lot of combinations, and then deacquisitions, a lot of rebranding. But you see these sort of same companies popping up over and over again. They tend to be privately held, either by private equity firms or by family offices. So there are few public reporting requirements. They're not subject to SEC disclosure requirements. They're not typically subject to Freedom of Information Act requests or the state analogs. So it's hard to get a lot of information out of them. They can tend to be sort of these black boxes. To talk a little bit about Massachusetts, the jails here use a combination of different providers. A lot of them use WellPath. Barnstable, Essex, Worcester County all use WellPath. Some of them use a company called CPS, or Correctional Psychiatric Services, which is a Massachusetts company. Bristol uses them. Suffolk used to use them. And then at least one county does something a little bit differently. Instead of having a privatized contractor, they have hired the doctors to work directly at the jail. And if I have time, I'll talk a little bit about them when we get to alternatives. That's Hamden County. DOC, which is the organization that runs the prisons here in Massachusetts, has a contract with WellPath. That contract was slated to expire at the end of next year, but it's been extended for another year while the department works on drafting a new request for proposal that'll start the bid process to see who will be the new provider starting in 2024. So Sarah touched on this a little bit. Our organization, Prisoners Legal Services, is a prisoner advocacy organization. One of the things that we do is we have intake where people who are incarcerated can call in or can write to us with the issues that they're experiencing, and we try to advocate for them. Not quite a majority, but a large plurality, I would say 40+% of the intake that we get revolves around inadequate medical care. So we are hearing constantly from our clients about ailments they have that are being ignored, sick slips that are being ignored, delays in care, including specialty care where outside trips are needed, failure to implement recommendations from outside providers, persistent understaffing issues. So we are acutely aware from conversations with our clients that they are suffering because of the inadequate medical care that they're receiving. And I think part of that has to do with this drive towards privatization. So I'll talk a little bit about some of the problems I see with the privatization. I think at sort of a high conceptual level, there's just a problem of misaligned incentives. These companies, like all companies, are focused on making as much money for their shareholders as possible by selling services to customers. The problem here is that it's not a typical customer. The customer is really sort of split between, on one hand, you have the patient base who is quite literally captive. They want the best medical services possible, but they have no option to switch to another competitor. They have no say in who is providing the services. And then on the other hand, you have the correctional facilities who are paying the bills, and their incentive is to pay as little as possible. So the way that shakes out is you end up with sort of the cheapest, lowest level of care that you can skate by with. Like there will come a point where it is so clearly unconstitutional or so unconscionable to voters that that will drive a change, but it will settle sort of right above that level, as low as they can sort of get away with and as cheap as they can get away with. There is also an issue with the way that the contracts with a lot of these providers are structured. They're typically structured as what's called a capitated payment model. So that sort of contrasts with a fee-for-service model or cost-plus model, which is more similar to, think about your private insurance or your Medicare or your Medicaid. If you need a service, say you could go to the doctor, you can get a knee replacement, and then the doctor will go to the payer and say, I performed this knee replacement, you pay me for the service I provided. And that's not the way these prison contracts are structured. Instead, what you get is they will get some pot of money, say whatever it is, $10 million, and then they'll be responsible for providing care to the prisoner population. And so instead of an incentive to provide services to get reimbursed, they have an incentive to deny services, because every service that they don't perform is money that they're not spending and that they just keep and goes to their bottom line. So you really have this incentive not to be providing medical care. And that's compounded by the fact that in some instances, there may be an incentive to provide care earlier when it's cheaper, before something develops into a bigger problem later. But that incentive is attenuated here because most people are eventually going to be released. 98% of people in jails or prisons are going to return to society. So these private companies know that if they can just deny care and delay care until that person is released, after they're out the door, they're no longer responsible for paying for the medical care. So even if it does become a larger problem down the line that they haven't gotten this, preventative care up front, it's not going to affect them because they're no longer responsible. So those are some of the structural issues I see with the way privatization is working in this field. And so, we can give you plenty of anecdotes about how that plays out, for our clients in horrible ways. You can also see it in the data. Reuters did a report in 2020 that found that jails that have one of the 5 largest private providers had 17 deaths per 10,000 inmates, compared to 13 deaths in jails where the healthcare is provided by a public entity. So you can see sort of in the mortality rates that this is driving worse healthcare outcomes for people. In terms of alternatives, there are a number of different structures that you could do instead of having a private provider. You could do a direct provision of care. That's something like what Hannum County does. They have the doctors there sort of on staff, which works actually pretty well for them. We don't get a ton of complaints from Hamden County. The doctors they're on staff at the jail. They're also employees at local community health centers and are on staff at local hospitals. So because most people at the jail release to the same area, you can have a continuity of care where you can have the same doctor, when you're inside and also when you're outside, so that there's no things lost in transition, which ends up with some better healthcare outcomes. So that works well for them. There are risks to all of these structures as well. Having medical professionals as part of the same entity that's running the jail, you have a risk that they get sort of folded into the security structure and they're not going to be able to operate with independence. So it's not clear that model is always going to be superior. Other examples, instead of a for-profit company, you could have a nonprofit company run the provision of healthcare. Some places have universities run the provision of healthcare. UMass used to be the provider for Department of Correction before they switched to a private provider. Or you could have a government agency here, like something like Department of Public Health. You could have them provide the services. So there are a number of alternative methods. I think there are, pros and cons with all of them. And it's probably don't have enough time to get into all of it tonight, but I would just like to say, sort of to echo what Sarah said earlier, it's not going to be, prisons and jails are not healthy places. And the solution is not just going to be as simple as switching from a private provider to some sort of public model. That might help part of it, but part of the problem is the built environment of these prisons, the isolation that's inherent to them, the culture of dehumanization that pervades them, the subordination of everything, including healthcare, to safety and security concerns. And those sort of deeper issues about what incarceration is in this country really make the provision of quality healthcare challenging, no matter who the provider is. And so I think, we can and should be thinking and working towards improving delivery of healthcare in jails and prisons, including by moving away from privatization. But we also, I think we have to be thinking about how to bring healthcare back to the community. And that requires thinking about how can we decarcerate as much as possible.
Catherine, you're muted.
Yes, thank you. Thank you, Michael. That was a lot of information,
Yes.
and I thought I knew a lot about it, but now I'm got a whole lot more to absorb. Angie, it's now your turn. I'd like you to give a little bit of your background and to just explain some of the things that you have experienced in the real world of living with these experiences. Angie.
All right. Good evening, everyone. My name is Angelia Jefferson. My pronouns are she, her. I am a formerly incarcerated woman. I was incarcerated for 31 years at MCI Framingham. While inside of MCI Framingham, the healthcare, like I always say, was 0 to none. You would get a few doctors that were okay, but they really couldn't do what they wanted to do because they were under this contract with WellPal. For me, I want to mirror something that Sarah was talking about as far as the bras and they don't fit right and all that other stuff, and they won't sell you the right size either. They call them medical bras. They'll call you down and say that they're going to measure you. And then when they measure you, they send the bra, and the bras that they give you, they call them medical bras. The bras are just not safe and not healthy to wear. I had major back problems, major shoulder problems, to the point where my spine was getting messed up and I was getting headaches because I was top heavy. For 31 years, I had to wear 2 bras because one bra wouldn't hold me and they just would not give me my right size. So I would wear a state bra and I would buy just my size bra. I would buy the biggest size that they had and I will alter it so it looked halfway decent. And I did this for 31 years while I was there because, like I said, by me being top heavy and not having a proper bra to wear, it started causing me all these issues. Right now, my shoulders are scarred from all the weight of the 2 bra straps on my shoulders that I had to wear. I used to get big knots right in the upper part of my back because all the pressure was pulling forward to the point where it was causing big knots across my back. And they used to give me muscle relaxers for that. They said, oh, it'll go away, muscle relaxers, do some physical therapy. The pain wasn't going away. It got so bad, they put me on the chronic care list. Now, the chronic care list is a list where if you have an ongoing issue, they're supposed to call you down once a month. They're supposed to evaluate you and take you through everything that you need. So for me, because I was having this issue, I needed a breast reduction. But they wouldn't give me a breast reduction because they said that it was cosmetic surgery. So I put in a grievance. They denied it. I put in a second grievance. They denied it. The last time I put in a grievance, they denied that one. But with this, one of the nurses came to the unit with the grievance in hand. And she said, I see that you put in the third grievance because you would like a breast reduction. So this is what we could do for you in order for you to get it. We could put you on the lowest dose of testosterone, and you will have to see a mental health provider for a year. And after the year, then you'll be able to get your breast reduction. So I'm looking at her like, first of all, I don't want to go on testosterone. I shouldn't have to go on that in order to get a breast reduction. So she says to me, point blank, the transgender women, that's what the procedure for them. That's how they end up getting their breasts taken away. They have to be on testosterone. They have to see a therapist. I told her I am not a transgender, nothing against them, but that's not what I want to do. I have a legit medical issue. You all is noted in you all's books that I have a legit medical issue. I've been out to the Shattuck for this and everything. It's legit. They would not give it to me. They denied me. And after I told her that I didn't want to take the testosterone and see the mental health provider for a year, that was it. They said that there was nothing that they could do for me. Only thing they could do for me is give me muscle relaxers every other month because they didn't want me to be on the muscle relaxers for too long. They would give them to me for 3 times a day. I didn't take them half of the time because they really didn't work. So my biggest thing was one day I'm going to get out of here. And when I get out of here, then I'll have it. Thank God I did get out. I ended up having the breast reduction in February. I got it in no more headaches, no more back pain, no more knots in my back. My spine's okay. Everything's fine now. Now, as far as I want to go back to what Michael was talking about as far as the 6 slips. You put in the 6 slips, the 6 slips are ignored. They do not. Now, you're supposed to put it in and be seen within 24 hours. Sometimes you get seen in a week. Sometimes you get seen in 2 weeks. Sometimes you don't get seen at all. But they make sure to charge you the $3 for the 6 slip that you put in. They make sure they get their money for that 6 slip, whether they see you or not, which I don't think is fair. The protocol is you put in the 6 slip, you get called down to the trauma room nurse asks you what's going on, what are your symptoms, blah, blah, blah. She writes it down. Then she's supposed to submit it to a nurse practitioner. It doesn't go like that. It does not go like that at all. I have a few friends in there right now. One friend lost one of her legs and half of her foot. Another friend has a colostomy bag. Another one of my friends, she's confined to a wheelchair for the rest of her life. All because this place is not giving them the proper medical attention that they need. One of my friends, the one that has a colostomy bag, in order for her to get the medical attention that she needs, she has to literally pass out for them to call a code 99. She puts in slips, she puts in her grievances and everything. They ignore everything. She calls her lawyer up there. Her lawyer's like, well, we need to get on this because this is an issue that she's having. She has around her scrotum, it's all, last time I seen it before I left, it was all raw to the point where she couldn't even put the bag on it. It was so raw. They said, oh, well, put talcum powder on it, put Gold Bond powder on it. It'll dry up, it'll go away. It didn't. She would have to sit in her room because she couldn't attach the bag because it was so raw around it to the point where she couldn't go out. She was confined to her room, because that's how she uses the bathroom, do that. So by them not taking care of her the way that they're supposed to, and another thing too, the supplies that she needs to keep this colostomy bag up, they never have them there. Oh, well, we'll give you 2 weeks worth, then we'll send out for more. After her 2 weeks is up, she goes down there to get her bag filled with everything that she needs. It's not there. Oh, the order didn't come in. We have to send out to the hospital to get it. It's just not fair. And then the other lady that got her leg amputated and her foot amputated, she put in for medical parole. They denied her medical parole because the prison said that they're providing her with everything that she needs. They gave her a walker. She can't walk. They gave her a wheelchair. She needs someone to wheel her around. And they gave her a cover for her toilet and a bar on the wall so she can pull herself up. That's not taking care of her health issues. That's just masking it and making it worse. The infections that sets up in these people's bodies. So many women in there, they have sinus issues, they have cancer. That's because all the mold and all the dirt and just everything inside the prison that they cover up with paint, with caulking, with wax, with anything that they can find to cover it up with. That's why a lot of the women have the issues that they have. My sinuses are just like 0 to none. They are crazy because of everything inside of there. A week before I came home, I was supposed to get surgery. I have knee issues on both my knees. So I went and they told me that they took an x-ray. They said I had a torn meniscus. Now, I don't know how they could see that through an x-ray, but they said that I had a torn meniscus and they put me in to get surgery. So a week before I came home, I was supposed to go to the Shattuck and get the surgery done on my knee because they said I had a torn meniscus. That's why I was having the pain. That's why I was swollen and everything. I found that I was coming home, so I denied the visit. Thank God I did. When I got out and I went to a real hospital and seen real doctors and got the proper care that I needed, I don't have a torn meniscus. I have arthritis on my knees. So if I would have went and they did surgery on my knee, what were they going to do when they went in? I have another friend that's out right now. I just seen her like last week. I seen her and they went in, she had a hemorrhoid issue. They went in to fix it. They never fixed it. She still has the hemorrhoid issue, but now she has a major scar in her bowel area. A major scar from what they did to her. She kept telling them that something was wrong. And that's the thing in Framingham. You tell them over and over and over, something's wrong, something's not right. I'm having these symptoms. They think that everyone just wants meds. Speaking of meds, now they mask meds. Okay, now they mask meds with Suboxone and methadone. That's what they use now for pain management. If you have any type of symptoms, you've never been on these type of medications, you've never done drugs or whatever. If you wasn't an addict, you're an addict now because they're going to force it on you. They don't want to deal with the medical issue. WellPath is the worst privatized healthcare there is. It is the worst. They do not do anything that they're supposed to do. The nurses, some of them say that their hands are tied. Some of them just do not care. It's not right. And then they want to build a new prison. And then this is another thing. They say that you can give up your organs and get a year off your sentence. How are you going to give up your organs when your organs aren't good? Because you're not getting the proper care that you need while you're inside of there. I wouldn't give up my organ anyway, but at the same time, if I was to give up my organ, I would want for my organ to be good going to someone. They don't take care of the issues with the women inside of MCI Framingham in order for them to be healthy. 9 times out of 10, the women that are getting out, he said 90% of the women get out of prison. The majority of the women that get out have major, major health issues when they get out. And it all stems from being inside of there and not getting taken care of the way that we should get taken care of. So that's why I said I will always be the voice for the voiceless, because there's a lot of women in there that their voices can't be heard. So I'm going to do any and everything that I can do in my power to help them with this issue. Mental health is just as bad. Mental health is just as bad. When we get around to that, I will talk about that. But the medical that's in the prison right now is so bad. I don't know where they get their degrees or whatever from, but They do not do what they need to do. And I understand that they have to follow a certain order that they have, but it's still not fair that the women aren't getting the treatments that they need. Thank you.
Wow, Angie, that was very powerful. Thank you so much. And I think if we have a couple of seconds to go, we might talk a little bit about mental health, and that might get us even more so. Sarah, do we have any questions in the chat yet for members of the audience, I guess?
They are rolling in right now. Hold on. Let me pull them up. I was asked a question previously about are there any communities for supervision or monitoring that can be provided to these privatized healthcare organizations?
Could you repeat that again, Ciara? I'm not sure I understood you.
Are there any kind of community supervision or monitoring that can be provided to these privatized healthcare organizations?
Oh, I think that's probably for Michael, huh?
Yes.
Yeah, that's a great question. And supervision is always very tricky. You know, I love that the question mentioned community supervision. We've had experiences in the past when you have, you know, some other supervision that gets co-opted by sort of the system and acts as sort of a rubber stamp. Like all of these, you know, all of these facilities are accredited by the National Commission for Correctional Healthcare and the ACA. And so if you have an accrediting or supervisory agency that sort of acts as a rubber stamp, in some ways you end up worse off than you were to begin with. So it's critical to get actual community supervision, you know, from members of the community who are affected by this, and supervision that has some sort of teeth to it. You know, I don't know that I've seen that, and certainly not in Massachusetts or any other jurisdictions that I'm aware of. But certainly, I think it would go a long way towards some improvements here.
The next question would be about the pandemic. So during COVID, were there any special provisions made in order to test, prevent, and treat COVID infections? And what can we learn from this that could be helpful in the next pandemic?
So during the pandemic, what they did was they moved everybody around. So they tested everyone, and the people that tested positive, they moved all of them to one unit. And when they moved everyone to one unit, they had to wait the 10 days, and then they retested them. And after they weren't, you know, sick anymore, they moved them back to the unit. But then more women were sick that were on the unit, so they had to move them back. It was just like a get up and go type of thing with them. Every day, you just never knew what was going to happen from day to day when COVID broke out. We were locked down 23 hours a day. They let everyone out, four women at a time, to shower, clean your room, use the phone, use the kiosk, then you got locked back in your room. The officers didn't want to come around and do anything. The nurses, you rarely seen them because they said they didn't want to come on a unit where the women were sick. And the majority of the time when COVID came into the prison, it was the staff that was bringing it in, because we weren't going in and out like they were. But they said that we were the ones giving it to them. So that's how that worked. If another COVID outbreak happens, I feel like they shouldn't do as much movement as they did, because I feel like by them moving so many people all over the place to different units, that's what messed everything up, and a lot more people got sick that way, if that makes sense.
And I'd just love to add, I think another thing that should have happened during the COVID pandemic that didn't, and I know I sound like a broken record on this, was decarceration. You know, there were a lot of efforts from advocates, incarcerated folks inside, families, communities to say, let folks out, particularly medically vulnerable folks, let them out, because prison and jails are not safe places for them. They're very dangerous. And one of those places that is just rife with, you know, people regularly interacting and passing illness to each other. And DOC really failed on that front. They did not do sufficient decarceration. They did not let people out, and they needed to. And, you know, another pandemic will happen. It's not a matter of if, it's a matter of when. And when it happens again, folks need to be let out. Folks need to be out here where it's safe, and it's easier to prevent communicable illness.
The next question is for you, Mike. Could you spell out the Supreme Court case that you mentioned previously?
Sure. It's Estelle v. Gamble, Estelle v. Gamble, Gamble.
Perfect. Thank you. And then, sorry, so much just happened on my screen. How can they legally use an addiction taper but deny specific medications? Would any of you know the legality of it, or is that more of a different type of person to question?
I don't know the legality. I don't know why they do that, but they just started doing that like about, I'll say like about 2.5 years ago, they started doing that. This girl that I know, she was having like a lot of back issues. And instead of them sending her out to the hospital or whatever, they offered her Suboxone. So when they offered it, she came back to the unit, she was crying and all upset and everything. Then as the weeks went on, we started hearing more and more people saying, you know, they offered me Suboxone, they offered me methanol for pain management. They said that is for pain management. That's what they're using it for. But that's also a private company too. They have their own people coming from the outside to distribute the medication. So I don't know, like, if it's a money thing, I don't know what it is, but whatever it is, they need to stop because it's just not right.
The next question would be for you, Sarah. You mentioned partnerships with community health services, which sounds like the best way to go. And how can advocates get through the red tape within governments to make sure these partnerships can happen?
Right. So to be clear, what I'm talking about is, you know, rather than investing more in corrections and incarcerating people, focusing on getting people out and using money that we would spend on these harmful systems to fund community health, and focus on decarceration and getting people help on the outside. I think in terms of, you know, starting steps is that there is a law pending right now in the legislature that would put a 5-year pause on the construction of new prisons and jails. It's colloquially known as the moratorium bill. It would put a 5-year moratorium on the construction of new prisons and jails, which would kind of give us the space to pause prison construction for 5 years, decarcerate, and fund community systems of care, including healthcare, mental health care, you know, care for crisis situations. In terms of, you know, improving the healthcare that's actually provided for folks inside, and to the extent that folks stay inside, I think it's something Mike could probably speak to a lot better than I could, and Mike, you did. But it's a really tricky process, I think, because the Department of Correction and everything that it does is so shrouded in mystery, and they're not used to being held accountable to anyone, and they're not used to, you know, being overseen and answering to someone else for their decisions. But even when it comes to, you know, private health care, I think it's a similar difficulty for overseeing because they're private, right? They're not subject, as Mike said, they're not subject to the Freedom of Information Act requests. They're not, and the state analogs, right? But certainly, I think in terms of like models, I think Mike could certainly speak to it better than I could. But I know you've already spoken to that, and I don't want to put you on the spot there, Mike.
No, that's all right. I'm happy to speak a little bit more about it. I mean, it's tricky because the Department of Correction specifically does not like to send people out to outside providers. It costs them money. You know, they have to get staff to go travel with someone. It's a hassle for them. They have to pay overtime. And so they put requirements on their providers to minimize the number of trips outside. So one of the sort of like inherent functions of our carceral system is to separate people, but keep the people outside, outside and keep the people inside, and to sort of drive a wedge, which makes engagement of a community provider very difficult because they are so sort of fundamentally opposed to it.
You just answered my next question in the chat, Sarah, but the question, I'll just read it out so everyone, in case you can't see it, can hear it. The question was, is the moratorium bill specific to Massachusetts or is it a federal bill? And Sarah said it was Massachusetts specific. And then the next question would be, how is the healthcare at Shattuck Hospital viewed, like compared to the other ones?
At Shattuck?
Yeah, sorry.
So Shattuck, people who don't know, Shattuck is the public hospital. DOC requires its provider to send people to Shattuck over other hospitals whenever possible. I have had clients who have had very terrible experiences there. I've had people who will refuse to go to Shattuck, even if they need a medical treatment because they do not trust the care there. There was just an article by Jennifer McKim I think she's at GBH now, about the culture at Shattuck and how, she interviewed a number of former physicians there who said they felt very unsupported by the administration and that they thought that was very problematic. So that's been my experience with it.
This is going back to the substance abuse treatment. Is it working or is it just what they're doing?
To me, I don't think that it is working. I think it's just making matters worse. Like I said, women that never had substance abuse issues, now they have these issues. So I don't think that it's working. And to piggyback off of the Shattuck, not only is the medical care there horrible, you're handcuffed and shackled all day from the time you get there to the time you leave, and they sit you in a cold cell with a concrete slab that you sit on all day long. If you have to use the bathroom, they take one hand out for you to use the bathroom, then they put that hand back in. You have to eat handcuffed. You have to do everything while you're handcuffed and shackled. And yes, the staff people at the prisons, some of them don't want to go. Some of them do go though. And like they'll go, and if you have a serious issue, some of them will come back and let everybody know what your issue is. Whether you want people to know or not, they will go and tell your business. And I don't think that that's fair either. I could sit here all night long and go on and on about all the, excuse my language, about all the bullshit that's going on behind the wall, because that's exactly what it is. Every officer in there isn't bad. Every staff person isn't bad. But at the same time, the mental health and the medical care is just shit. Something really needs to be done. It really does.
I just wanted to add on one small point with regard to medication-assisted treatment. I think one strong irony, and again, I keep putting you on the spot, Mike, but you probably could speak to it better than I could. I think one strong irony is that, it sounds like based on what Ms. Angie is describing, that folks who are not dealing with substance use disorder are being prescribed medication for substance use disorder for pain management, which is not supposed to be its use, while people who actually are dealing with substance use disorder and are seeking medication-assisted treatment for their substance use disorder aren't able to access it in a lot of prisons and jails. And I think that's such a deep irony of the situation around MAT. And also, Ms. Angie, to your point about, officers discussing your medical business, I think that's just so indicative of the deep culture of indignity that permeates systems of corrections, both in prisons and jails. And thanks for that really poignant example.
Yeah, I think.
Sorry, you go.
Sorry, I'll just say MAT. Sarah's right. DOC is now supposed to be offering MAT at all its facilities. They're not doing that. They're offering some medications at some of them. There are often these requirements that are not supported by the medical literature, that, you needed to be prescribed medication before you became incarcerated, which we know, people from certain neighborhoods or areas or backgrounds are less likely to have access to those medications beforehand. So it's discriminatory because you can't get them when you need it after you've been locked up. There are they require things like having dirty urine tests before they'll put you on a medication. They'll force you to use one medication when another one is better suited for your your personal substance use history and toleration. So there are a lot of problems with the way MAT is being run, and it's being run. It used to be run by WellPath. It's now being run by another private provider called Spectrum. So it's just another example of privatization and the problems with it.
Those are the only questions I've saw. If there's any other questions, you can put them in the chat and then I can say them off in the next 2-ish minutes.
Thank you. Actually, I have a couple of questions I didn't put in the chat. Angie, you were mentioning, and I think Michael referred to it, when you have services within as an incarcerated person, do you have to pay for them?
No, you just have to pay for the 6 slips.
For the what does that mean?
Like say for instance, if I have an issue, if I need to be seen by a provider, I will fill out a 6 slip and I'll drop it in a 6 slip box. They go by and they take it out the box, they read it. Like I said, sometimes they call you down, sometimes they don't. But yeah, I have to pay for that 6 slip.
And do you have to pay for that?
Yes.
I must admit, I thought I knew a lot about this, but I have just learned so much tonight. A question.
It's $3 for each 6 slip you put in. So if I put in a 6 slip every day, I would pay $3 for each 6 slip that I put in. And if you don't get seen, you don't get reimbursed. If they don't see you, you don't get reimbursed.
Okay, my question for Michael is the contract for privatized health services with the whole Department of Correction with the state of Massachusetts, or does each facility contract with a separate privatization organization?
So the Department of Correction has one contract for all of the prisons. And then each of the jails are run by county sheriffs. So each jail is separate entity and will be contracted separately at the county level. But there's one provider for all of the prisons at the state level through DSC.
Okay. Any other questions? I'm sure that everybody else has learned as much as probably as maybe I've learned more than other people have, but any other questions or comments before we finish up with this? One of the things, if there aren't any, one of the things I would like to mention is that, in fact, one of the participants on the webinar this evening is a member of the American Public Health Association, and they have put together a policy statement for the whole organization relating to shackling of prisoners during healthcare. That will be on the resource list, and anybody who wants to make a comment on that or to support it, etc., can send it. You do not need to be a member of the American Public Health Association. You probably just need to be a member of Concerned Society. And as we finish up, we know that one of the things that the pandemic has highlighted to a lot of people that were not aware of it is how dysfunctional our total healthcare system is. Part of that is that we don't have, we spend too much money on the wrong kinds of things, and healthcare is really public health. It's a lot of the social aspects of housing and education, etc., that relates to our health. And we don't have a lot of those resources because we spend so much money on our defense budget. So that's just to make sure that we have that in the back of our mind. And then when we look at healthcare for incarcerated women and incarcerated persons in general, we just realize that it is just even a highlight of what goes on with the larger system. It's more than just healthcare. It's the whole aspect of what goes on within the healthcare system. So I think we have a couple of minutes, and I'm going to put all of our speakers on the spot for a minute and ask you what you think we can do. We can do not just as members of Massachusetts Peace Action, but as just regular residents of the state of Massachusetts, of the United States, what we can do to perhaps make some changes within the healthcare services for incarcerated persons. Sarah, why don't we start with you? I'll put you right on the line.
Sure. I would say call your state representatives. I think really the first step here is getting the moratorium bill passed so we can stop this new women's prison and start investing in community care, decarcerating folks, investing in community care, including community health care. So I would say calling your state representatives, your senators, your representatives, and asking them to support the moratorium bill.
Thank you. Michael?
I'll add call your federal representatives. If one sort of topic I didn't touch on is there's a federal policy called the Medicaid inmate exclusion policy, which excludes, it's a congressional law that was passed in '65 that excludes from Medicaid coverage or Medicare coverage anyone who's incarcerated, even if they would otherwise be eligible. And so I think, there are bills proposed to repeal that. I think the lack of Medicare coverage, a public option for people who are incarcerated, is one of the things that drives this privatization and this lack of healthcare. And so I think that's one avenue that hopefully might see improvement.
Angie, I'm sure you have some comments for us.
Yes, call your state representatives. At this point, call the president. Call anyone that you have to call. We do not need another prison. We do not need another women's prison built. We don't need any more prisons here, period. What I feel as far as like privatizing the medical staff that's in Framingham right now, they need to get rid of that. They need to get rid of that. They need to bring real doctors. I talked on last month, I talked on a panel with like 20 doctors at Boston Medical, thank you. I talked to a panel of doctors at Boston Medical, and they were asking me, like, what is it that they can do to change this? And my biggest thing was show kindness, show that you care. Because a lot of those medical people, mental health people, they do not care. And they let you know that they do not care. They show it in the way that they treat us. They show it in the way that they care for us. They do not care. Show kindness. Take the women out of that prison, shut that prison down, do whatever it is that, oh my goodness, that's going to make their lives better. Some of them, like I said in the beginning, have so many health issues right now to the point where they feel like giving up. Every now and then, if I can talk to them, I talk to them to try to give them that extra push that they need to hold on to hope. Because at this point, the way that the prison is treating them is just not right. So please call your state reps. Like I said, call the president. Call the president. Let's get out there. Let's do rallies. Let's do free hers. Let's do whatever it is it takes to get these women out of there and the men, and get each and every last one of them the proper health that they need.
Thank you. Thank you, everyone, for participating and being part of our session this evening. And I especially thank Sarah and Angie and Michael for a wonderful presentation. And I do believe, I suspect that you've raised everybody else's consciousness and awareness as much as you have raised minds. So thank you, and I hope we can all work together to bring about some changes, not only with the incarcerated health system, but with the larger health system and what we will be doing. Thank you all and good evening.
Thank you for having us.
Thank you.